Well, good afternoon, everyone. Thank you for joining our quarterly morbidity, mortality, and improvement grand rounds. My name is Georgia McIntosh, as you might know. And today we're really excited about being able to present something that has been important and really challenging for the management and recognition for our patients. So we have a big panel of providers that are going to be talking about this. I do want to introduce our two main presenters first. So immediately to my left is Dr. Kristen Miller. So she is an associate professor in the Division of Pulmonary and Critical Care Medicine. She is a powerhouse, as anybody that has been working with her knows. Kristen went to med school here, went to residency here, and then completed her fellowship here. So really is a VCU product, and we're really happy that she has been here and has stayed here. She is currently the medical director for quality in the MRICU, and her interests are in neurocritical care, pulmonary oncology, and bone marrow transplant, and especially medical critical care, and has been on faculty here for over 11 years. And then our other presenter is Dr. Bhardwaj, who is the quality director for the Division of Cardiology, and is the director of our Echo Lab. She's an associate professor, joined in 2011. She, opposite of Dr. Miller, went to med school at UVA, did residency at UVA, and then came here for fellowship and has been on staff since 2011. Her expertise is really in non-invasive imaging. And so I'm going to turn it over to Dr. Bhardwaj and Dr. Miller to get us started.
Great, thank you, Dr. McIntosh, for that wonderful introduction. So today we're going to be talking about hypertensive urgency versus emergency, navigating the gray zone. So just a few slides talk about our MMI conference. The goals are to learn from medical errors, complications, and unanticipated outcomes. We want to engage our faculty and learners in a rational discourse surrounding a critical incident or near miss. We want to diagnose system errors rather than identify individuals, and to increase transparency regarding organizational improvement efforts. So we have some ground rules: avoid finger pointing, try to see yourself as a physician involved, use statements like they should have, use I wonder statements, they should have, confidentiality, no identifiers for any of our cases today, and help discover the fixes and ways we can improve care for future patients. So our objectives for today are to increase awareness of serious safety events by providing a case presentation and analysis of a serious safety event, to differentiate hypertensive urgency from emergency, and then identify the key components of a proposed hypertensive emergency algorithm. So our framework is to first discuss the case, then discuss urgency versus emergency, and then we'll have a panel discussion with our wonderful doctors here, Fatani, Keiser, and Keiser, and then system solutions with Dr. Nguyen and Keiser towards the end. We have no disclosures. All right, to begin with the case. So this case is a 53-year-old female with end-stage renal disease on dialysis. She has hypertension, coronary artery disease, mildly reduced EF. She has COPD on 2 liters of home oxygen, bipolar disorder, and she presents to the emergency room for altered mental status. She regularly attends her HD sessions, but missed today's session. So her vital signs on presentation, you can note her blood pressure was 215 over 114. She was afebrile. Her heart rate was 91. Respiratory rate was 17, and she was satting 100% on 4 liters. 2 liters is her home requirement. Her physical exam, she's thin, sleepy appearing, cardiovascularly, regulating rhythm. There's a possible S4. She has an AV fistula in the left upper extremity with a palpable thrill. Her respirations are non-labored. There's no wheezing or rhonchi. And I want to point to the neurological exam. She's somnolent, slow to answer questions, and oriented only to herself, but moving all extremities. So we have a timeline of this patient in the emergency room. So she arrives in the emergency room at 19:30. Her blood pressure, we said, was 215/114. Her initial lab work shows hyperkalemia with a K of 6.2. Her lactate is 3.1. She has a mildly elevated troponin at 0.54, and her BNP is greater than 5,000. Her creatinine is elevated, and renal is paged for emergent dialysis. Short time later, very short time later, the ED notices that her altered mental status is worsening. She's not appropriately responding to questions. She gets a subsequent chest x-ray. She's given labetalol for her blood pressure. It improves slightly. Her blood pressure improves to 179/106. Nephrology note states resume home blood pressure medications. And at 2300, about 3.5 hours after presentation, hemodialysis is initiated. Her blood pressure at that time is 197/104. So she completes dialysis at 2:30 in the morning. Blood pressure is still elevated. Repeat labs show her K has improved to 4.5. Her troponin has gone down. They order a head CT near 5 a.m. That head CT shows there's moderate symmetric bilateral white matter low attenuation, which could be related to a chronic process or hypertensive encephalopathy. No other acute findings noted. The emergency department subsequently places an RFA to medicine for altered mental status and hypertension. Repeat blood pressure at 8 a.m. This is the next day is 221/126. Lactates improved. So the MAA places an urgent consult then to the CICU for hypertensive emergency. Subsequently given some more labetalol and then Haldol for agitation. The MAA is called. The MAA speaks to the CICU who says resume home medications prior to admission to step down. So that's what the MAA requests that of the emergency room, to place the admission hypertension meds. Blood pressure at that time is 170/70. Okay, 9 o'clock in the morning, she's given clonidine 0.3, hydralazine 100, Iserdil 20, and metoprolol 25. Blood pressure, 30 minutes or so later, is now 82/49. So remember, her systolics were in the 200s. Now her blood pressure is 82/49. She's given IV fluids. She's placed in Trendelenburg. More IV fluids are given. She still has altered mental status, and the CICU was recontacted for possible pressor needs. Blood pressure started improving slowly with IV fluids. Subsequently, at 1:30 the next day, the CICU places an admit order, and her blood pressure is noted to be 109/70. So the key point here throughout this whole timeline is the patient, remember the patient arrived to the ED at 7:30 p.m. the day prior. We finally have an admit order at 1:30 the next day. This is the EKG. So she had many EKGs in the ER, in the ED. This is one of them. It shows normal sinus rhythm. She has these mild ST, slurring and depression. So evidence of some endocardial ischemia. It shows obviously LVH, which she's had on prior EKGs. This is a graphic trend of her systolic blood pressure, so you can know how high she was, and then she falls to the blood pressures in the 80s after giving those 4 medications in the emergency department. So it was a drastic drop, and then her blood pressure starts coming up slowly with IV fluids. So of note, this patient was discharged from medicine 5 months earlier for sepsis in the setting of the flu. Per that discharge summary, they had continued clonidine, hydralazine, Iserdil, and metoprolol. But after she became hypotensive, there was concern that the patient was not taking all of her medications. So when they really reviewed her medications, it seemed like she was only on clonidine and hydralazine, and compliance may have been an issue. So what are our key findings with just what I've stated? So there's a lack of consensus about management of hypertension. There was a delay in the disposition for the patient that needed admission. And there was incorrect medication reconciliation. The blood pressure medications administered in the emergency department were obtained from a discharge note from 5 months prior. A A subsequent external prescription history review showed clonidine, hydralazine, isoprene, metoprolol had last been filled 3 months ago by the patient. So this is just one case, and we want to all bring the point that this has happened more than once, and that's why this is good that we're reviewing it. There have been a history of similar safety incident reports where a patient has presented with hypertensive emergency, another patient with hypertensive urgency, both receiving what was thought their home antihypertensives and with subsequent hypotension and bradycardia. So this just exemplifies that this is not one case, there have been many. So I want to talk a little bit about the analysis of this. So this case was deemed a serious safety event, SSE. And when that occurs, we look to see if there was permanent or temporary harm. Fortunately, in this case, there was only temporary harm. And what happens when a case is defined as an SSE is a group of folks, doctors, pharmacists, nurses, APPs come together, they're stakeholders, and they review the case in detail. They review it at length. And they look for reasons that why an adverse event happened and what we can do to avoid that from happening in the future. So this slide shows what analysis came out of a stakeholder meeting reviewing this case. So I want to just point your attention, there's some root cause analysis, and then SC is a suboptimal condition. And that's something, a condition that occurred that maybe didn't directly lead to the adverse event, but definitely played a contributing factor. So for the root cause, number one, so 2 root causes were found. For number 1, due to limited inpatient beds, emergency department and team capacity drives the common practice of providing multiple interventions in the emergency department prior to team acceptance and bed placement, with the hopes of getting a patient to a lower level of care. This increases the ED length of stay. And then the second root cause is there is no expectation and a lack of resource for focused medication history and reconciliation in the emergency department for planned admissions. This is generally done when a patient is admitted to the primary team. The 2 suboptimal conditions, which we're going to delve into a little bit more. The first being there's inconsistent diagnostic criteria and treatment algorithms for hypertensive urgency and emergency across the organization. And that's where Drs. Miller and Nguyen will talk more about that. And then the second suboptimal condition is there is a lack of a clearly defined process in place for communication between the emergency department, the MAA, and consulting service providers, and that Dr. Keiser will tackle. Now, I'm going to give the floor to Dr. Miller to talk about differentiating urgency and emergency.
Great. Thank you, Dr. Bhardwaj. Appreciate the opportunity to talk to you all today. This is a tough topic, and it definitely has some gray zone characteristics. So our hope is to make this a little bit more clear by going through some case examples and some of the literature. So we're going to start with tackling differentiating hypertensive urgency versus hypertensive emergency. So in reviewing the literature and look at guideline statements and publications, there's a general consensus that hypertensive urgency, although there's no perfect blood pressure and can vary for different patients, it's generally equal to when the systolic is equal or above 180 or diastolic 110 to 120. But the key with urgency is there's not acute hypertensive mediated target organ damage. And I'll talk a little bit more about that, as well as Dr. Nguyen will as well. The patient may or may not have symptoms related to hypertension in hypertensive urgency. And with urgency, many patients can be safely discharged following monitoring and or treatment. The key to this is that the follow-up needs to be very soon, within a couple of days to a week. So if that's a concern, patients may end up needing to be admitted to evaluate. But it's much more common than hypertensive emergency. So in contrast, hypertensive emergency is using those same blood pressure characteristics, generally equal or above to systolic of 180 or diastolic of 120, with acute hypertension-mediated target organ damage. And that's the key here. So I'll give you some examples of what's considered acute mediated target organ damage. Hypertensive emergency truly is an emergency, and these patients should be in the intensive care unit. It's associated with morbidity and mortality and requires immediate treatment. Not to say that hypertensive urgency shouldn't be treated, it's just that the risks and problems associated with this actually can occur much longer during the line. So in months to years, there will be more complications. Emergency, we need to treat immediately. Let's give you some examples of target end organ damage. I've actually cited a New England Journal of Medicine article here, but also used some of the guidelines from the American Heart Association and other publications. So we'll do things by systems, typically how we tend to look at things in critical care. So in terms of target end organ damage with the brain, so what you may see is an ischemic stroke. Intracerebral hemorrhage often can occur in the setting of uncontrolled hypertension. I can show you here, this is an example of an intracerebral hemorrhage. In patients who have hypertensive emergency, often you'll see an intracerebral hemorrhage in the thalamus or in the brainstem. Another phenomenon is called posterior reversible encephalopathy syndrome. There's a lot of things that can lead to PRES, but in particular, hypertension can cause PRES. What about in the back of the eye or the retina? You can see papilledema, and some patients with hypertensive encephalopathy, you may be able to see that on fundoscopic exam. You may see hemorrhages, exudates, cotton wool spots as well. What about the heart and the lungs? Well, in the lungs, you frequently can see these curly B lines, interstitial edema, alveolar edema, related to the heart and congestive heart failure. You may have an NSTEMI, or an acute congestive heart failure exacerbation, where patients may be hypoxic, their x-rays may show edema as well. One clinical scenario that really warrants abrupt treatment of hypertension is aortic dissection that you can see here. And what about kidney injury? Well, Dr. Fatani will talk a little bit more about acute kidney injury and target organ damage, but some of the things that you may see are rising creatinine, and as well as proteinuria and hematuria. And at the microvascular level, you may see this microangiopathic hemolytic anemia from target end organ damage from hypertension. So these are all examples of end organ damage in association with hypertensive emergency. So I also wanted to give you a case vignette that was in this New England Journal of Medicine article. Frequently, it's a good resource if you want to read about a topic, and many times they'll give you a clinical vignette. This one is a little bit more clear-cut than our example. I'm not going to go through all of it, but I just wanted to talk about a few things here. It's a 58-year-old woman who has a history of hypertension. She admittedly has not been taking her blood pressure medications for about 3 weeks. She presents with headaches, blurry vision. Her blood pressure on multiple seated blood pressure measurements is 242/134, heart rate 68. Physical exam is significant for flame hemorrhages and papilledema. She also has a fourth heart sound. EKG shows LVH, indicative of chronic hypertension in this case. And the head CT is interesting in that it has this hypoattenuation in subcortical white matter, which explains some of the blurry vision complaints that she has. This patient actually has posterior reversible encephalopathy syndrome. You see these areas here of hypoattenuation and then T2 flare on the MRI. This is causing symptoms, neurologic symptoms, which include blurred vision or can also cause cortical blindness. So when we look through and try to differentiate hypertensive emergency versus urgency, we look at that blood pressure. We want to make sure that that blood pressure is checked a couple different times with an accurate device. And then the immediate next question is, are there findings of acute target organ damage, such as intracerebral hemorrhage, PRES, or suspected hypertensive encephalopathy? Are there findings on fundoscopic exam? Does the patient have pulmonary edema or heart failure? Are we concerned that this patient may have aortic dissection or worsening kidney injury? The answer to that is yes. The algorithms and most consensus statements recommend admission to the intensive care unit. You want to use IV therapy here. Many, and Dr. Nguyen will talk a little bit more about this as well, but frequently clobidopine is used because it's such a rapid on and rapid off IV infusion. And then you want to lower that blood pressure according to the organ injury. And that actually varies quite a bit. So with aortic dissection, you need to be very aggressive with getting the blood pressure down. Whereas if you have a patient that might be having some neurologic changes or has an ischemic stroke, you're not going to lower that blood pressure much at all. But in this scenario, you would want to start to lower that blood pressure again in the pattern of organ injury. And then after the patient has stabilized and you've gotten that reduction, then you can consider stepwise approach of oral antihypertensives. In a patient, in contrast, that has hypertensive urgency, where they don't have these acute target organ damage, actually there's been an interesting study of about 500 patients that if you allow the patient to have 20 to 30 minutes of quiet rest, about a third of those patients will have a reduction of their blood pressure without medication to about 10 to 20 millimeters of mercury. So you could consider that. And then you want to ask yourself, does the patient have, if they don't have acute target organ damage symptoms, do the patients have symptoms attributed to high blood pressure, which means that you might need to monitor that patient a little bit more. And some of those symptoms may be epistaxis or headache, for example. If the answer is yes, it could be that you want to give a rapid oral agent. Some of the ones that have been used or suggested would be oral labetalol or clonidine. You want to adjust this patient's long-acting antihypertensives, and then you want to discharge when the symptoms have improved with, again, very close follow-up. If the patient has no symptoms attributed to the high blood pressure, then you want to adjust long-acting antihypertensives and, again, have very close follow-up. So kind of going back to our case where the blood pressure was initially very elevated, and then once the patient received those oral antihypertensives, why is it important? I think this is an important question to address. Why do we not want to lower this blood pressure too quickly? Well, it really focuses around physiology and in particular autoregulation. So autoregulation is a phenomenon that occurs in many organs, brain, heart, and kidney. But I'm going to focus actually on the brain for this example. It's also been shown that lowering the blood pressure too quickly in a patient that can present like this can increase that patient's mortality. So this is kind of a busy slide, but I think it really shows a great example of what autoregulation is and how the physiology leads to some of these neurologic changes that you can see with hypertensive emergency. So the brain has a phenomenon called autoregulation. When you look at this graph here, this is mean arterial pressure here, and here is cerebral blood flow or cerebral perfusion pressure. The neat thing about the brain, and many organs also, is that over a very wide range of mean arterial pressures, the blood flow to the brain stays constant. So the brain can really compensate. However, when that blood pressure gets too low, i.e. if the blood pressure falls too quickly with medications, this is where you run into the risk of causing ischemia, i.e. a watershed infarct. In contrast, the pathophysiology between hypertensive encephalopathy is when that blood pressure gets too high, the blood flow becomes too much, it causes brain edema, breakdown of the blood-brain barrier, and what you see clinically is hypertensive encephalopathy, or actually intracerebral hemorrhage. And frequently that intracerebral hemorrhage in patients with hypertension, again, is in the basal ganglia, thalamus, or brainstem, or cerebellum. So we're going to shift gears a little bit now to our panel. We appreciate everyone coming today, and we're looking forward to hearing your perspectives and your insights and your expertise. I'm going to turn things over to Dr. McIntosh.
All right, thank you, Dr. Miller. So we've assembled a panel of providers from different disciplines just to weigh in on some of the challenges that we see in managing these patients, especially in the emergency room when we're trying to both treat as well as determine the appropriate level of care and the appropriate place for these patients to go to. So we have Dr. Imran Fatani, who's one of our nephrologists in the Department or Division of Nephrology. Dr. Jessica Keiser, who is our medical director for hospital medicine and frequently acts as a medical admitting attending. And then Dr. Ramana, who is one of our emergency room physicians and is currently the interim chief quality and safety officer. So thank you all for joining us today. I'm going to start with Dr. Fatani. So one of the things that is frequently a challenge is patients with hypertension and evidence of acute kidney injury. And this is one of those, I think, a subtle finding that we often see with patients, and it's hard to know how significant that we should take that. Do you have any guidance or approach in terms of looking at acute kidney injury in the setting of hypertensive emergency?
So thank you, Georgia, for that question. I think it's always a challenge when you're evaluating a patient that comes in the emergency room that may or may not have prior history. The way I approach acute kidney injury with hypertensive emergency or not is the same way I approach any acute injury, is to determine whether it is acute or not. And one of the ways we can identify that is based on a KDIGO classification or a Kidney classification or Referral criteria to see whether they have acute kidney injury. That can be based on the urine output, which is 0.5 milligrams per kilogram per hour for less than 6 hours is about stage 1, or later rise of greater than 0.3 milligrams per deciliter. The reason why that's important is that at first you have to identify, is it actually acute? And if they come to the emergency room, a lot of times, as we've seen, we don't know whether they're based on fatness, but we can certainly follow their evolution of the disease that's there. But irrespective of now, once you have identified they have hypertensive emergency based on their numbers, but we're not sure if the target organ damage is there or not, and it happens to be that we see elevated creatinine, the next step is to identify what could be the presentation in this patient. So common findings in someone who has hypertensive emergency and an AKI, you happen to have elevated creatinine, but also you have hematuria and subnephrotic glomerulonephritis usually. Outside of that, it's difficult to tell on the initial presentation whether the kidney is involved. Very seldom do you perform biopsy in these patients because of the high risk of complications that are there, patients that have uncontrolled attention. So that's the initial evaluation that goes in, and as time evolves and the patient is admitted in 24 hours, you have a better idea whether this is from hypertensive emergency or not.
Yeah, I think that's, at least for me, when I'm in that position, it's hard for me, and I appreciate just thinking through how do we assess that acute component. And I think one of the things that I don't do as well, and I think will be helpful, is to look at that UA to see if there is evidence of hematuria.
Absolutely. I think it's important to keep in a differential diagnosis. There are many things that can cause renal failure and hypertension. However, the important thing is that it's not necessarily important that we understand at that initial instant that what is the cause of renal failure. Is renal failure causing hypertension or is hypertension causing an AKI? The point is that the patient has end organ damage and they have hypertensive emergency based on that criteria. Now, we have to lower that down gradually because we are seeing organ damage that's present there.
Thank you. Dr. Keiser, so as somebody that frequently sits in the MAA position, does this clinical question come up frequently? Does this feel relevant to you, or?
Yeah, I think it's very common for us to get a referral from the emergency department, and there's this question if they do have hypertensive emergency. Though I often see that instead of wanting to say hypertensive emergency and that the end organ damage is a sequela of that, I think often we kind of look at other things that could be on the differential. We end up saying, well, their blood pressure is high because they missed dialysis, or their blood pressure is high because they are in heart failure. Not necessarily that the heart failure is because of the blood pressure. I think we all seem to have a tendency that even though hypertensive emergency is on the differential, it's not usually as clear cut as that case where you're like, oh, look at these findings on imaging. Oh, I got my eye exam, which I don't know the last time I did that, to be quite frank, on an RFA I got as MAA. But, and so I think we get stuck in this kind of gray zone where it is on the differential, but there's also a whole lot of other things it could be. And then you get kind of following that downstream is, what can I offer this patient in terms of level of care? Now, if I follow the level of care guidelines, for progressive or step-down medicine, I need to have a patient with a systolic blood pressure less than 200 or within 20% of their baseline. So if we have someone who's been in the ED multiple times and their blood pressure is like always 180, 190, and then they come in at like 210, well, that's someone that I can argue is close to their baseline and I can bring to step down. But if I have someone who 200 is significantly higher than their normal, by the current level of care guidelines, that patient really should be referred to the ICU. Also, if I'm not able to adequately control their blood pressure with IV pushes or oral meds, that patient should be referred to the ICU. And I think when you're in the MAA chair, you get stuck in this position where you have someone who's just on the borderline of progressive level of care versus ICU, may have hypertensive emergency, but the differential's broad, and the question becomes, what direction do we go? And I hate to say it, but I do think capacity often will direct that conversation. Because if there are no ICU beds available in the hospital and people are hanging out in PACU, we're probably going to try to see what we can do a lot more in the ED with IV and orals prior to getting them a medicine team on a step-down bed. And so I think as MAA, we get stuck in that position a lot where we're like, well, let's just try one more thing. Let's try one more thing. Because we're trying to get them to a point where I can get them to a bed that I might actually have. And I think that just happens quite a lot when you get those referrals. Hopefully that answered the question.
Yeah, and I think that's helpful because, you know, oftentimes I don't know that I look at what their previous trend is, and I don't necessarily have that calculation of looking at 20% of their baseline blood pressure. And so that might be a good guidance as long as there are no other very obvious end organ damage effects that I can see, just to see what their previous blood pressures are compared to their acute presentation.
Yeah, and I think then, like we saw with this case, you get stuff where your ICU colleagues who might be involved in the case, you have MA involved in the case, you have the ED, and everyone's just trying to get that blood pressure down to a safe value that can get them in a bed. And I think in that situation, we often do things not like the algorithms would tell us. Because I'm not starting you on a drip and bringing it down a certain amount over a certain amount of hours. We're usually giving you a push or giving you an oral med, and then just hoping that that blood pressure does not drop too precipitously.
Yeah. So that brings me to Dr. Keiser as one of our emergency room providers. How frequently do you come across this variation in practice, both from, you know, talking with different providers, different MAAs, or even within providers that you see in terms of management of these patients?
Yes, thank you for that question. I think it's hard to quantify how often we see it, but we definitely see it. I think this serious safety event and even the example of other safety events shows it's happening. And I think it's easy when they're in one of two buckets, meaning they have no symptoms or they have active end organ damage. So the head CT is abnormal. They have a troponin of 10. They have the aortic dissection, whatever the findings might be. So I think it's in the middle group, the gray zone group, if we want to call it, where it's not clear cut, is this hypertension, urgency, or is this emergency? And so that's where I think as a system, we can do a lot of work, and some of that work is being presented here to reduce that unwanted variation in that middle group with standardized algorithms that work for the whole system. So no matter whether the patient is located in the emergency department or located on a floor in the hospital, that patient would get, you know, those same kind of principles applied to their care. And just by having that shared understanding and common goals and talking through like what are our concerns to either sway us more towards their urgency or more towards they are an emergency. And by talking it through, I think we'll be swayed to one side or the other and put that patient in the group. And regarding the capacity and throughput concerns, I think in the end, if it means another patient needs to be designated as ICU, that's what we want to see happen, even if that means they have to hold in the emergency department. We don't want there to be compromises on the care that we want that patient to get just because our capacity is full. And then what we need to figure out as a system is once we've decided we have another patient that needs an ICU, even if it's a short stay ICU, what are the options there? And I think, you know, that's going to be larger work that we're doing as a system to look at how do we get that patient that ICU care while they need it, even if they're still located in the emergency department.
Yeah, thank you for bringing up that system piece and the issue of variability. That was something that when we had Dr. James that came last week, that really emphasized that clinical variability, while sometimes it's appropriate, if there's so much variability, then you really can't expect a sustained outcome. And so limiting that variability as much as possible when we identify what that patient needs is really what the system needs to do.
Yeah, and to build on what you just said about Dr. James, when we establish these algorithms and these system-wide solutions, we'll definitely need to look at measures of success, meaning data. So what happened after we instituted these algorithms? What did it look like as far as either patient cases that we bring forward that still had issues despite the algorithms we put in place? Of course, safety events is a way to monitor for that, or just cases that we each bring forward. So that way we can keep adding layers to what we initially introduced. And then looking at data, like looking at where did these referral for admissions go? And did they end up going, you know, to that floor bed, or did they really need ICU? What complications were they having? And then that way it can, by looking at that data, it can better inform us any additional actions we want to take.
Thank you. Dr. Fatani, I do have another question. So, you know, as we've identified that patient that is has a blood pressure that is, you know, we've identified that it's outside of their range, and we like to bring it down, patient with end-stage renal disease. Are there any criteria that you use that would say that this is a safe pressure that we can safely do dialysis? Is there anything that you use to make that decision? So it's a very common consult we get where patients, unfortunately our patient population has uncontrolled hypertension on a regular basis, so we see this quite frequently. So when I evaluate a patient, I don't go based on cutoffs of numbers, but more on the clinical presentation that's there. So there isn't a particular blood pressure that I'd say is safe or unsafe to dialyze or not dialyze, but more what the presentation is. As in the case, this person who is in the emergency room, I would first identify whether there's a need for dialysis. So go back to the medical school mnemonic from MCD, AEIOU. Is there hyperkalemia? Is there acidosis? Is there volume overload? There's toxicity. If those factors are present and there's a need for dialysis, then I evaluate whether is dialysis safe for this patient or not. And then I break down into two categories, which is what are the risks and what are the benefits. So one of the highest risk of complications or complications in our ESRD population is stroke. They're about 10 times more likely to have an ischemic event and 3 times likely to have a hemorrhagic conversion of those ischemic events than the general population that is not having a failure. So when I'm looking at this particular patient who presents with ultramental status and who has a head CT that's concerning the possible encephalopathy changes that are there, possibly pressed, which we can't see from the CT, my level is quite high concerning that this person may have hypertensive emergency. And so then I have to make a decision on whether it is dialysis safe, because as Kristin mentioned about the cerebral perfusion pressure is depending on mean arterial pressure and intracranial pressure. And one of the challenges of dialysis is that it causes intracerebral pressure variation, even in patients that don't have a CVA. So how does that happen? Well, you have osmotic changes that are taking place because you're rapidly clearing urea, or electrolyte shifts that are there, or volume shifts that are there will affect mean arterial pressure.
So it can cause changes in cerebral perfusion pressure. So in the case where if this person had a CDA and we put them on regular dialysis, there's a risk of complicating this further. So I will look at this patient, see if this person has evidence of CDA. I get a CT first, looking through this algorithm that was here, and actually looking at how the case evolved. I would have done a CT first when the patient presented as opposed to waiting after dialysis to make sure that there's no acute CDA that's there. Now, you don't always are able to tell ischemic events on CT, but at least you can tell if there's hemorrhagic CDA that's there or not. And if there is a stroke, and it's a large stroke at that, I would consider doing CRT in the ICU setting to reduce the risk of complication that's there, if that's the situation. The other aspect that I look at also is there a concern for an MI? If the patient who's sitting in a dialysis chair or presents to the ED now presents with acute chest pain, I would want to make sure that we have cardiac enzymes, EKG, as was done in the case of this, make sure there isn't an acute myocardial infarction that's taking place, because, as we all know, dialysis is a very stressful event to the body. So when the person is having an MI, and we do dialysis on that patient, we're effectively putting them through a very stress test during that procedure. So those things are what I evaluate, and if dialysis can be delayed safely, if we think there's no emergent indication, I'd rather do that in those two circumstances. So that's how we approach that.
All right, thank you. Thank you. I think it's challenging, and I think there's a lot of kind of decision trees that, that we're all going through at that same time. All right. I'm going to turn it back over to Dr. Bhardwaj and Dr. Miller.
Well, thank you to our panel and Dr. McIntosh for that really good discussion. I agree. It truly is a gray zone when we look at this. But to tackle our system solutions, I'm going to turn it over to Dr. Nguyen and Dr. Keiser. This is really tackling those suboptimal conditions, the one being the inconsistent diagnostic criteria for hypertensive urgency emergency, and the second being the lack of a clearly defined process in place for communication between the ED, the MAA, and the consulting service providers. So, Dr. Nguyen, I'll turn it over to you.
Hi, thank you so much for having me. My name is Tammy. I'm one of the ED clinical pharmacists here at VCU. So one of the items that came out of the serious safety event is that across the institution, we don't have an algorithm that clearly defines what we say is hypertensive urgency or emergency. So one of the goals from the serious safety event was to develop that for the entire health system. So what we did was we gathered documents and data from the various areas of the hospital that have kind of a significant stakehold in this. So we pulled it from the ICU, the emergency department, internal medicine, and really tried to develop an algorithm that could be utilized for the entire hospital as a whole that we could, despite our specialty, come to an agreement on. So if you go to the next slide. So this is currently what we have developed, and what you can see is that it's actually very similar to what Dr. Miller presented previously from New England Journal of Medicine with regards to the definition of when should we really consider hypertensive crisis, emergency, urgency, with that definition of systolic blood pressure greater than or equal to 180 and diastolic greater equal to 120, and that target organ damage. What you'll notice on here is that acute kidney injury is not on there. Dr. Fatani brought up some great points with regards to definitions, and we will definitely add that in there. Just in the emergency department, our perspective is that that's not something that we're able to readily evaluate, but definitely something that we can add in. If you look at the target organ damage, you really ask, is that present? And if the answer is no, then we consider that hypertension. And really the goal is facilitation to follow up and decreasing the blood pressure gradually. If the answer is yes with target organ damage, then we have those clearly defined goals of decreasing MAP by no more than 25% within 60 minutes, and then slowly decreasing it subsequently over the next 2 to 6 hours. We put in there, consider restarting home medications once medication dosing and compliance has been confirmed based on those previous safety events. And there are conditions with alternative blood pressure goals, including what was mentioned before, which is aortic dissection, ischemic and hemorrhagic stroke. And as part of the algorithm, there's a table there that defines what those blood pressure goals are and what the recommended treatments are. So beyond these initial tables, there's also that orange table to your upper right-hand corner, and that's really consider other etiologies of acute hypertension, just to make sure that we are looking at this in a broad way and not just really focused on hypertensive urgency, emergency, making sure that we address if there's any other contributing etiologies. So what we would really like is to have feedback from anyone who, we will take all feedback. Just because we really want this to be a document that can be utilized by the entire health system, regardless of specialty. And I don't know if Dr. Keiser has any other comments on it.
Yes, and I think possibly in the next slides, oh, okay,
Yeah.
actually, do you want to touch on this first?
Oh yeah, so the document for the algorithm, that previous slide with the yes, no, et cetera, that's kind of the first page. The document's actually 7 pages long as it reviews all of the various disease states and the evidence supporting various blood pressure goals. But really the focus for us is hypertensive crisis, or in this case, hypertensive emergency, really understanding here what it outlines as the definition, what our therapeutic goals are and our disposition, and the understanding that there's additional hypertensive crisis results in many types of different organ damage, and that our preferred agent is parenteral, and as Dr. Miller mentioned, the clopidogrel is one of our choices and titrated to the target goal.
Yeah, so at this point, we can go to the next slide. So what Tammy just covered was a draft of the hypertension algorithm that we need everyone possible to look at. And I have my email up there, so happy to get feedback. And so we'll have to make sure that full document does get circulated out to all of you. This document has been reviewed at a monthly meeting that we have that is emergency department and internal medicine, and that occurred on Friday, April 2nd, and we incorporated edits from that meeting. Then we brought it to a different monthly meeting that involves the emergency department, the KICU, the MRICU, and the MAA team, the hospitalist medicine team. That was on Monday, April 5th, and we got some additional edits there that we also incorporated. We're here today for this MMI, so hope to get additional feedback from that. This also is scheduled to go to 2 other groups on April 19th, so next Monday. One of which is critical care committee. So again, we want this to be system-wide. This would be for adults. You know, it would not apply to pediatrics, but at critical care committee, we can at least have all of the other ICUs involved with reviewing it, both at a physician and nursing level. And then also one of our nursing leaders is bringing it to progressive care committee on that same day to look at what Dr. Keiser mentioned, which is the nursing level of care. As was mentioned, when you look at that level of care guideline under progressive, there's certain blood pressure numbers, including how does it compare to baseline. And so we want to really carefully look at that again, because we don't want to be treating numbers. We want to be treating the patient as far as, you know, what pathway we follow. And then we also have one of our residents doing this as an M&M later this month. And so the algorithm covers management. When you look at disposition, it was really going to be hard to capture that in an existing algorithm for management of a disease condition. And so some things that have come about at the system level related to other patients and events that go on is the gray zone and undeclared level of care algorithms. I'm hoping each of you know about it, and if you don't, please email me and we can get that information out again. But it's meant for system-wide use for patients largely probably coming through the emergency department. Gray zone refers to this patient needs ICU, but we're not sure which ICU. And that's because they often have more than one condition going on, or they have a condition going on that can be taken care of in more than one ICU. And so knowing that these patients are super sick, we want to, you know, figure out in a very clear way of communication and escalation, which ICU do they need to get to, so that way they can start getting that ICU care. And so hypertensive emergency would fall in this bucket. It becomes more clear if they're having a stroke or an intracranial hemorrhage, which unit that might be, or what services that might be. But then other ones like this patient that was described that had altered mental status and maybe some EKG changes, some borderline troponins, the kidney issues, which unit would that be? And then undeclared level of care refers to the progressive step down versus ICU level of care. And so this patient fell in that category of, is this an emergency or not? And so things to do to resolve this would be, I think we have to decide within this pathway if hypertension is the disease condition we're talking about, are they urgency or are they emergency? And let's get consensus on that, because that way we know what pathway we need to follow. We need to look at the nursing considerations in deciding level of care, because even if we as physicians are finding, oh no, they seem okay, we need to look at all the things that the nurses need to do, and is this okay that they're at progressive level of care versus they really need ICU. And then I think when there's debates going on, that's where we need to have more proactive attending involvement and accountability to help all of our learners as we make these decisions, and make sure that it involves timeliness as well. And then this last part also is a way of making sure we have standard communication. We learned that as we develop the gray zone and undeclared level of care is that sometimes we're using referral for admissions. So that's a decision to admit order that the emergency department places on patients once we know the service and the level of care that they need. And then consults, usually that's going to be where we have a question for a consultant, but the expectation is not admission. So if we know we're contacting somebody because we need them to be admitted to your service, it should all be done as a referral for admission to clearly communicate it. So in this example, the ED team felt like it was more urgency, and really they were admitting the patient for altered mental status, didn't feel like it was at the level of emergency, put this referral for admission into medicine. And then medicine was having concerns for this patient that we think this might be emergency. They're contacting the KICU team, but it was done as a consult, and we're trying to restructure that we would have preferred that it be done as a referral for admission instead, because the way the team that's receiving that order, it gets handled in a different way. If you get a referral for admission, you think of it as they're contacting me to admit this patient, take ownership of this patient's care. Whereas consult is, I'm just answering a question to help give advice to another team to help manage it. So this consistency will just help us when we're communicating what we want for this patient, and then it'll help with escalation when that's needed.
Great. Thank you, Dr. Nguyen and Dr. Keiser. And just to wrap things up, and admittedly using the retrospectoscope, back to the case that we described, Dr. Keiser brought up a great point that many times these cases aren't as clear-cut as what our guidelines show. It's not as straightforward as that vignette that was from the New England Journal of Medicine article. But this patient was hypertensive, and there was some concern for the altered mental status and hypertensive encephalopathy with EKG changes. I wonder if an earlier ICU admission may have been considered in this case and using IV therapy. And just one other comment, you know, there's not a lot of great data about how quickly to lower the blood pressure in some patients, and you really do need to use clinical judgment. But one thing's recommended in a case like this would be to lower the blood pressure by about 20 to 25% in the first hour. That's what is in the American Heart Association guidelines as well. And then try to aim for around 160 by 100, 160 over 100 by 6 hours. If that point the patients had a good response and not a lot of lability, it'd be advised to then start oral antihypertensives in a stepwise approach. We realize though that there are definitely gray areas, and I think the point about really good communication and use of consultants and experts in these fields would be also very helpful for our teams. So some take-home points. Diagnosing a hypertensive emergency can be challenging, but don't forget about trying to look for that evidence of acute end organ damage. And then if patients who have hypertensive emergency, they should receive IV therapy and ideally ICU level of care. That target blood pressure goal and timing of lowering the blood pressure really depends on the organ involved in the diagnosis, as some of the examples that we talked about. And then patients who have hypertensive urgency, i.e. the elevated blood pressure without evidence of acute end organ damage, they can have the reduction of blood pressure over longer periods of time, hours to days, but it's really important that they have close follow-up. So thank you so much for your time and attention, and we'll be monitoring any chat or questions on Zoom.
So we have one question with regard to the consult versus the RFA. If the MA is the one who thinks admission to the CCU may be more appropriate, should they put in the RFA? And should we ask the ED MD to enter the RFA? This person says, I feel like the MA has been asked to handle dispo once the RFA to medicine has been placed, at least historically. So I'll pass that on to Dr. Fieser and Keiser.
Yes, thank you. From what we put out, we would like the use of RFAs. So it's different if the admission order has already gone in. You can't put additional referral for admissions at that point. So if something changed after the patient is admitted, those would be done as consults and then transferring the service and the attending and level of care. But if it's before the admission point, we do want there to be a second referral for admission put in, so that, and we want to be kept in the loop for that reason too. So usually what would happen is that primary service, so in this case medicine, would let us know, we're worried this is emergency, we're calling the KICU. So we would go ahead at that point for the emergency department to put the referral for admission into the KICU. What's greatly appreciated is when the MAA does go ahead though and talk to the KICU person, but at the same time when we're placing that RFA, it is paging that team. So that way that team can also call us back if they want to get additional information about everything that we had from our perspective. And also it reminds us in the ED that we still need to, we still have primary ownership of that patient. That patient hasn't been admitted to anyone and we need to actively care for that patient. So I think it serves a lot of good purposes. But I think in the end too, KICU would have then also realized, oh, I'm being contacted for admission, not just a consult. And so how that gets handled would be, treated in a different way as far as what the patient needs might be.
So we have a couple of chat conversations. Marco says, one point to think about is patients with scleroderma when they present with hypertension and rising creatinine. He recently participated in a code blue of a patient who came from the ED overnight to medicine early in the morning because they were treated as hypertensive emergency and the scleroderma renal crisis was not recognized. The patient did not receive captopril or any other ACE inhibitor. The patient unfortunately passed away. I think she had scleroderma renal crisis that wasn't recognized.
So
Dr. Fatani?
I think that raises again another point of why it's so important to have a future mutually as part of the target organ that's there. Look for hypertensive emergency. And this is for the reason why you should have that differential to rule that out.
Great point. And then we have two questions really surrounding RFAs and will RFAs be used for all ICU consults on the floor? And can someone comment on the timing of RFA? Algorithm mentions 2 to 6 hours of monitoring, but my experience, this person's experience is RFAs are placed very quickly and the expectation is they will be disposed within an hour.
So for the first question, I don't believe RFAs work on the floor because they're already admitted. So I think there it's consults and then transferring to that service and to that level of care. And then for the second question, that is correct. Best practice would be, so referral for admission means decision to admit. Best practice would be that these patients do get ownership and inpatient care starting an hour or within an hour of that referral for admission to be placed. I think the majority of admissions, it is more straightforward like that, and that happens. We know that a patient like this is more complicated, and so when there's delays that are going to occur for patients that are more complicated, there just needs to be really tight and clear communication going on, because in general, and also things like if one ICU is slammed and they're coding patients, if they just update us, you know, that this is what's going on, we're gonna like be reasonable about, oh, we're not gonna just hold you to that hour. And same thing on our end, if we're like really slammed, maybe this will be one that you can admit in a more timely manner. Like, so I think a lot of, and sometimes patients do need some additional actions done. Like, you know, we only have so much information, but we should have enough information that we feel good about the service that the patient that we've chosen to admit to and the level of care. So I think if there's pending things like a head CT or troponin, we truly don't know what the level of care is and those kind of things. But and so I think we have an opportunity to learn about that, and that's something we keep talking about in the ED is we don't want to be putting these in prematurely. And I think for the most part we don't, but when we do have those things, I think these are opportunities for all of us to learn. So we need that feedback, and we're happy to review anything where we could have done something different or better.
Excellent. I don't think we have any more questions. We would like to thank you all our panelists, and thank you for all the participants for listening. I think this is very valuable hour we just had. Thank you. Please reach out to us if you have questions, further questions. Thank you.